Nervous system, part 2. There are two main families of neurotransmitters that are differentiated by their speed of signaling, functions, chemistry, and anatomy. The major amino acid transmitters, glutamate and gamma aminobutyric acid, or GABA, are the most prominent rapid transmitters and are present in the brain in the greatest concentration. The rapid actions of glutamate and GABA are mediated by ionotropic receptors, although each of these transmitters also has a metabotropic receptor. Transmission by small molecule amines and large peptides is more diffuse and modulatory in character. These transmitters usually target metabotropic receptors having relatively slow and prolonged synaptic effects on postsynaptic targets. Cell bodies of neurons containing amine and peptide transmitters are characteristically found in tight cell clusters in the brainstem or hypothalamus. Amino acid glutamate is the main excitatory transmitter. It's rapid. GABA is the main inhibitory transmitter. Glutamate is the principal excitatory transmitter of the brain. As an amino acid, glutamate is found in all cells and tissues. The significant difference between AMPA receptor activation and NAMDA receptor activation is that the opening NAMDA receptor channels increases intracellular calcium in postsynaptic neurons. Transient calcium elevation in postsynaptic cells is the key to the long-term consequences of NAMDA receptor activation, including a role in learning and memory function. The release of glutamate into the synaptic cleft is followed by binding to one or more types of postsynaptic glutamate receptors. Binding of glutamate to these receptors opens ion channels permeable to sodium and potassium, the AMPA receptors, or to sodium, potassium, and calcium, the NAMDA receptors. Remember that the significant difference between AMPA receptor activation and NAMDA receptor activation is that the opening NAMDA receptor channels increases the intracellular calcium in postsynaptic neurons. The summary of glutamateric transmission. Synthesis of glutamate in the axon terminal and packaging into vesicles. Then it's the release of synaptic vessels when the action potential reaches the terminal. Next, there's diffusion across the synaptic cleft and binding to ionotropic and metabotropic glutamate receptors. This causes excitation of the postsynaptic cell with depolarization and increased intracellular calcium. The diffusion of glutamate away from the receptor and the uptake by the secondary active transport either into a nearby glial cell or to a presynaptic terminal. The glial cell conversion of glutamate is to glutamine. Glutamine release from the glial cell and returns to the glutamateric neuron terminal. The conversion of glutamine to glutamate and repackaging into the vessels then occurs. The principal pathophysiological condition associated with glutamate neurotransmission is excitotoxicity, where neurons are literally excited to death by excess glutamate transmission. Conditions associated with exotoxic neuron death include states of hypoxia and ischemia, like stroke and traumatic brain injury. In these conditions, excess glutamate is released due to local depolarization, causing rapid action potentials. GABA is the principal inhibitory transmitter of the brain, and it is widely distributed in all brain regions, primarily in local interneurons. The GABA-A receptor is modulated by a variety of drugs of the barbiturate and benzodiazepine classes and by ethanol. Drugs that enhance GABA transmission are indicated as treatments for epilepsy, anxiety, and insomnia. Sedation, drug tolerance, and dependence are adverse effects of GABA-A agonists. The GABA-B receptor is a metabotropic receptor. When GABA binds to the GABA-B receptor, the cascade of intracellular signals opens potassium channels, closes calcium channels, and inhibits adenylene cyclase, reducing cyclic adenosine monophosphate, or CAMP. This overall results in slow inhibition. The anti-neoplastic drug baclofen is an agonist at the GABA-B receptors. Epilepsy syndromes are defined as disorders in which recurrent and unpredictable seizures occur. Seizures are episodes of highly synchronized action potential activity by large numbers of cortical neurons. Seizures are routinely time-limited, lasting less than 2 minutes, but worst case is status epilepticus, an unremitting seizure state that requires prompt aggressive treatment. The onset of epilepsy is most common in childhood, and epilepsy incidence increases after age 60. Pharmacological management of epilepsy is through anti-epileptic drugs that target ion channels and transmitter receptors to decrease excitation or increase inhibition. Phenytonin blocks fast sodium channel activity, inhibiting action potential formation. Valproic acid blocks both sodium and calcium channel activity. EEG recorded during a seizure of a patient with absent epilepsy. Synchronized electrical activity is seen across all the leads of the EEG, indicating simultaneous electrical discharges in large numbers of cortical neurons. Successive waves of depolarization and repolarization of many cells last for several seconds before spontaneously ending. The remaining transmitters are distinctive in that the overwhelming majority of their receptors are metabotropic, having slow effects on membrane potentials and exerting other second messenger-mediated postsynaptic effects. Many of these transmitters are associated with changes of behavioral state, including sleep, waking and alerting, hunger and satiety, emotional responses, and pleasure and motivation. Acetylcholine is abundant in the peripheral nervous system. It can act at metabotropic, muscarinic, and ionotropic nicotinic receptors. Cholinergic neurons in the brainstem are implicated in the initiation of rapid eye movement sleep. At a central cholinergic synapse, the neurotransmitter acetylcholine, when the transmitter is released from the presynaptic terminal, the postsynaptic response depends on the presence of nicotinic and muscarinic acetylcholine receptors. Acetylcholine is degraded by the enzyme CH15 into acetic acid and choline. The presynaptic terminal has a choline transporter to recycle choline for new acetylcholine synthesis. Dopamine, norepinephrine, and epinephrine are all catecholamines. There are a few epinephrine neurons in the brain, but the major physiologic role of epinephrine is outside the brain because it is the principal circulating adrenomedullary hormone. Along with serotonin and histamine, norepinephrine and dopamine cell bodies are found in anatomically identified clusters in the brainstem and the hypothalamus, with wide projections throughout the brain. Nigrostriatal dopamine modulates motor control circuits and assists with the basal ganglia function of enhancing motor programs that are learned throughout practice. The nigrostriatal pathway degenerates in Parkinson's disease, and the motor manifestations of the disorder are primarily due to this loss. Dopamine is also enriched in the gut as a signaling agent in the enteric nervous system. Dopamine antagonists can be used to treat nausea. Parkinson's disease occurs when substantia nigra dopamine neurons degenerate, thus depleting the striatum of dopamine. This disrupts motor processing circuits, produces tremor, rigidity, bradykinesia, and postural instability. The pharmacologic management of Parkinson's disease can include antagonists of cholinergic transmission. Dopamine is synthesized in a two-step process. In the first step, the amino acid tyrosine is converted to dopa by the enzyme tyrosine hydroxylase. In the second step, a carboxyl group is removed from the enzyme dopa decarboxylase, producing dopamine. Dopamine is packaged into vesicles and released into the synapse, where it diffuses to the postsynaptic membrane and can bind to the excitatory D1 or inhibitory D2 receptors, as well as other DA receptor types. DA release can be regulated by presynaptic D2 inhibitory receptors. The DA transporter is responsible for the uptake of dopamine to the presynaptic terminal, where some of the transmitter will be repackaged into vesicles and other molecules will be degraded by the enzyme monoamine oxidase. A general function of cerebral norepinephrine is to set the tone of behavioral arousal and responsiveness. Norepinephrine can also influence motivation, mood and affect, and descending norepinephrine pathways to the spinal cord also modulate pain transmission. Central norepinephrine transmission will also stimulate sympathetic nervous system outflow, increasing heart rate and blood pressure. Certain antidepressants non-selectively, like tricyclic antidepressants or SNRIs, decrease the activity of norepinephrine, increasing the synaptic concentration of this neurotransmitter. Noradrenergic synapse. Noradrenaline is synthesized from dopamine. The role of platelet serotonin is to promote vasoconstriction. Serotonin neurons are implicated in sleep-wake transitions, in arousal and motivated behaviors, in appetite regulation, and in pain modulation. Serotonin may inhibit aggressive behaviors. The efficacy of SSRI drugs in alleviating depression and anxiety points to a role for serotonin in mood regulation. Serotonin is also implicated in pain modulation as depicted in the serotogenic synapse. Histamine is a multifunctional physiological mediator serving as a locally active agent of inflammation, a modulator of gastric acid secretion, and a central neurotransmitter. Histamine neurons are active during wakefulness with increased activity during slow-wave sleep. The well-known sleep-inducing effects of non-selective histamine antagonists, such as diphenhydramine, are an indication that histamine contributes to the state of wakening. Many peptides are found in neurons, and these signaling molecules serve similar roles to the small molecule neuromodulators. The multipurpose nature of peptides and their location and action in the periphery often led to their discovery outside the nervous system before identification of their location and roles inside the nervous system. Peptides are short proteins, and these transmitters are synthesized by the process of transcription and translation in the neuron cell body. Receptors for peptide transmitters are metabotropic, having slow postsynaptic effects. Neuropeptides tend to be involved in slow neuronal responses and modulation of behavioral states, rather than rapid motor activity or reflexes. Morphine and the opioid analgesics are the most effective medications for severe pain, but their use is accompanied by the risk of tolerance and substance use disorders. The ability to reduce pain and provide analgesia without suppressing other sensory modalities is the central functional consequence of opioid administration and its clinical use. Other actions from opioid administration include the perception of pleasure or reward, mild sedation, and neurologic depression that, if severe, can lead to respiratory depression, as well as decreased bowel motility leading to constipation, and it can also cause cough suppression. These are major neuropeptides as well as their actions in the body. The waking state is characterized by low voltage, high frequency EEG waves, indicating widely distributed electrical activity that is not synchronized. The transition into sleep shows slowing of EEG activity and progressive synchronization, indicating depolarizations and repolarizations of large regions of the cortex. The deepest stage is referred to as non-rapid eye movement, stage 3. After varying amounts of time, there is a brief return to a lighter non-REM sleep stage before progression into the rapid eye movement sleep. Muscle tone in most muscles of the body is lowest during REM sleep, although brief twitches may occur. The extraocular muscles are active and produce eye movements characteristic of this stage. Sleep will then become lighter and more fragmented with age. This image indicates sleep cycles during the night in a young adult and an older adult. The cycles usually begin with the transition from wake to non-REM sleep, descending to the deepest stage, N3, before ascending through N2 and N1, and then finally into REM sleep. The cycle repeats several times during the night. In young adults, the deepest non-REM sleep occurs earliest in the night. In older adults, there is little or no time spent in N3, and sleep is more fragmented with frequent awakenings. Activity in the brainstem centers increases during awakening in several of the chemically identified neuron groups: norepinephrine cells, serotonin cells, acetylcholine cells, and glutamate neurons. These groups comprise the ascending reticular activating system, ARAS. This projects to the hypothalamus, basal forebrain, thalamus, and the cortex. Within the hypothalamus, axons from orexin cells of the lateral hypothalamus and histamine cells in the tubulomammillary nucleus add to the ARAS projection to the basal forebrain arousal region. With the basal forebrain, acetylcholine, glutamate, and GABA neurons, these are all intermixed. These neurons have cortical projections that initiate and maintain awakening. The orexin neurons of the lateral hypothalamus are strongly indicated in stabilizing the wake state, as autoimmune destruction of these cells results in narcolepsy, in which episodes of sleep occur throughout the day and night. Interactions between rapid-acting glutamate and GABA transmission, modulated by slower-acting small molecule transmitters and peptides, help shape sleep homeostasis as well as sleep disruptions.